June of last year, the Prime Minister announced at my old hospital, the Royal Free Hospital, a funding settlement for the NHS in England for the next 5 years. And that was really important for two reasons. First reason was that the funding increase, which averages 3.4% in real terms, is a move back towards the sort of average real-term growth that the NHS has seen over its 70 years, and away from the smaller real-term growth that we've seen during a period of austerity. So that means there will be more money over the next 5 years that we can invest in patient care. And secondly, it was a funding settlement over the course of 5 years. So it was a guaranteed increase averaging over 5 years. And that's important because rather than the yearly funding settlements that we've had, which then get revised and reset each year, it means that we have certainty of funding over 5 years, and we can think about setting a strategic plan for the NHS that isn't 1 year at a time. So that's really important. A few things that it wasn't, that it's also important to point out. Firstly, it wasn't a funding settlement for education and training, for Health Education England. It wasn't a funding settlement for Public Health England. It wasn't a capital funding settlement, so it didn't include capital requirement around buildings and kit. And it wasn't a funding settlement for social care, which of course is part of the local government settlement. And we're expecting all of those funding settlements to occur later in the year as part of the comprehensive spending review. But those are also important components of health and social care in England, and it's important that the funding in those services supports what we can do in NHS England. So the Prime Minister didn't ask for many things as she made that funding settlement, but one of the things that she quite recently asked for was that NHS England went away and it thought about a strategic plan for the next 5 to 10 years so that it could inform taxpayers, the public, citizens who fund the health service in England, what it was that the NHS was going to do, what did it want to achieve for that 5-year funding settlement. And so over the course of last summer and the autumn, NHS England, together with its many partners, including the Department of Health and Social Care, Public Health England, HEE, etc., spent a lot of time planning and thinking about what should go into a strategic long-term plan. And to do that, we held as many engagement events as we could. We invited comments from the public. We worked with stakeholders such as the Royal Colleges and the specialty societies. We could have, I'm sure, always have done more and more, but we had a limited time in which to do it. And actually, at the end of it, it seemed that an awful lot of people had been able to contribute, including major charities. And then in January, at the beginning of January, as you all know, we published the long-term plan. So some of you will have read it, and if you haven't read it, some of you will have seen the summary of it or heard it talked about. So what I want to do today is to give you a little bit of thought about the rationale for what underpinned what is in the long-term plan. And as I say, it's really important because it is the direction of travel, it is how we are going to deliver healthcare and what we're going to focus on over the next 10 years. So the long-term plan sets out a number of different things for the next 10 years. Firstly, it signals a move which we have been trying to make, I think, since the inception of the NHS towards prevention, towards preventing illness rather than treating acute illness. Secondly, it sets out a move towards treatment and management much closer to home and a focus on population health. So a move away from hospital settings into primary care and community care. And again, that's a journey that we have been on over a number of years, but which we need to accelerate. It puts a focus on inequalities, which I'll come back to later, and reducing inequalities in health. And it puts a focus on the way that we want to organise the health system to deliver those things. And then finally, maybe most importantly, it puts a focus on those conditions, those disease conditions, those conditions of poor health that we particularly want to focus on over the next 10 years. And we set about thinking about which conditions to focus on, looking at a number of different data sources. So this is one of them. This is data from the Global Burden of Disease studies showing the top things in terms of public health, prevention, but health conditions and illness that we most need to focus on because they are the biggest contributors to premature mortality and morbidity. The other things that we looked at were the very many reports that were published during last year which compared the NHS with other healthcare systems around the world. And those reports really told a very similar story, whether it's the Commonwealth Fund, a New York-based international healthcare think tank, or whether it's the Nuffield Trust, a more local think tank here in the UK. And what that told us was that in terms of universality of access, the NHS, as you would expect, is the best in the world because it is founded on the principle of universal access to healthcare. When you look at productivity and output for the amount of funding that goes in, again, we do very well. The Commonwealth Trust and Nuffield Trust rank us very highly. We do very well, actually, now on access to healthcare in terms of timeliness of access and treatment. So that's really been the story of the last 15 years. And the major improvements that we've seen in waiting times, both for acute conditions and for elective conditions, has really taken us into the pack when you compare us internationally. But there is one area in which we need to do better, and that's in health outcomes. And it's in health outcomes in a particular range of conditions. So in cardiovascular disease, in respiratory disease, in cancer, and to an extent in child mortality, we are lagging behind our comparator healthcare systems. Our premature death, our long-term survival is not as good as it should be. Now, that's not to say that we haven't made great advances in all those areas. We have. Cancer survival at 1 year is just over 70% now across all cancers, which is better than it's ever been. Deaths from heart attacks has been reducing over the last 10 to 15 years. But we have further that we can go, and there is more that needs to be done. So that is why those conditions, in particular, are at the heart of the long-term plan. Now, when I was looking through the drafts of the long-term plan and working on it with colleagues over the autumn, as a renal physician, from time to time, a little bit of worry occurred at the back of my head that there wasn't a section in the long-term plan on renal disease. And the reasons are that we wanted to focus on those conditions that cause the greatest disease burden, where there's the greatest opportunity to improve, and I've just highlighted that to you. But it still concerned me a bit as a renal physician that maybe you wouldn't want me to come and talk at the Renal Association because there wasn't anything specific, there wasn't a chapter in the long-term plan on renal disease. But of course the truth is there is plenty in the long-term plan for the renal community to focus on. And if you read it, I'm sure you will spot those opportunities. So what I'd like to do today, having given you the context for why the long-term plan is set out as it is to take 5 key features or 5 key things in the long-term plan and ask you to think, maybe challenge you to think how you can translate that from the long-term plan into work for the renal community and into benefit for our patients and people and communities that have renal conditions. So, the first thing I'd like to think about is cardiovascular disease. So I've given you the reason why cardiovascular disease is a focus of the long-term plan. 7 million people in the UK are affected by cardiovascular disease, and it accounts for 43% of deaths amenable to healthcare. And when you talk about cardiovascular disease, you very quickly also need to think about diabetes. So 4 million, around 4 million people in the UK have diabetes, about 90% of those type 2 diabetes, and maybe between 500,000 and another million people who have diabetes but have not yet been diagnosed. And of course, diabetes is a significant risk factor for cardiovascular disease and cardiovascular death. So cardiovascular and disease and diabetes are intrinsically linked. We know the causes of cardiovascular disease, blood pressure, cholesterol, obesity, and obesity, of course, is a risk factor for diabetes. We know that we could do much better, so that we know for people with hypertension, in the UK, only 37% have their hypertension controlled. And that compares to 53% in the United States and 66% in Canada. If we could manage cholesterol to the level that our colleagues manage it in Sweden, there's an estimated 25,000 cardiovascular deaths a year that could be prevented. So that we know that there is much more that we can do. Diabetes, as I say, is also a major factor for cardiovascular disease, and in the last 20 years, driven by obesity and an increase in obesity, we've seen a doubling in the number of people with diabetes. So there is more to do in diabetes prevention, and particularly around the management of obesity and health lifestyle choices. Now, I also don't need to tell you that cardiovascular disease is a major cause of renal failure. So chronic kidney disease, if you look at the figures in the renal registry, between 40 and 50% of people starting dialysis have as their primary cause of renal disease diabetes or cardiovascular disease, such as elevated blood pressure or renovascular disease. And I also don't need to tell you that cardiovascular disease is a major cause of death in patients with chronic kidney disease and on end-stage renal failure programs, including transplantation. Now, it is, of course, the case that the nature of cardiovascular disease and the drivers of cardiovascular disease in those with chronic kidney disease is a little bit different from the general population, but nevertheless, there are common risk factors. And coming into chronic kidney disease and renal replacement therapy with cardiovascular disease is not a good place to start in terms of long-term outcomes. So there's a huge opportunity for the renal community as we focus on cardiovascular disease to get involved and to start to make a difference and to start to impact on that incidence and prevalence of cardiovascular disease in renal disease. Now, I don't need to tell you, you all know, because when you were training either at medical school or university or wherever you trained, in whichever profession you're in, that the risk factors for cardiovascular disease include high blood pressure, obesity, and high cholesterol. We have known that for years and years. So the challenge is really not what the risk factors are, it's what we do about them. I remember a few years ago organising a conference on uremia with David Wheeler, who's in the audience here, and my colleague at UCL, and Colin Bagent, who may not be in the audience, but many of you will know, works in the clinical trials unit at Oxford. And we spent 2 days with experts from around the world talking about the drivers of uremia, whether it's superoxide or free radicals or a whole lot of other interesting molecules. And at the end of that conference, Colin says something I always remember, which is, if we had just spent as much time focusing on managing blood pressure as we do on trying to elucidate new molecular mechanisms that act at the margins of renal disease, actually we'd make a much bigger difference. And the truth is that we need to do much better as a renal community, but also as a community of physicians and clinicians as a whole in managing these common conditions. So that's why the long-term plan really focuses on the how rather than the what. So for diabetes, the diabetes prevention program, which we started a few years ago and has already treated around 100,000 people, will be expanded, not only for those who are at risk of diabetes, but for those who have BMI over 30. So really focusing on prevention, and what NHS England and our teams in primary care can do is going to be really important. Cardiovascular disease, we need to focus on better blood pressure control. In stroke, we need to focus better on the management of atrial fibrillation, and I will come to that in a minute. So I will pledge that as we work on the cardiovascular programs at NHS England, and I have the privilege of leading that, I will ensure that the renal community is involved in those discussions, as well as the British Heart Foundation, the Stroke Association, and others. But I would like you to work locally with your local systems to ensure that you do as much as possible to support primary care and others in detecting and treating the risk factors for cardiovascular disease. Now, the second topic I wanted to touch on is on how care is going to be delivered. So we have spent probably 30 years in England working in a system which is predicated on choice and competition, competition between trusts, commissioning mechanisms in which commissioners contract providers to provide services, and a funding system which is payment by activity, fee for service, paying for the volume of activity rather than necessarily the outcomes of activity. And we want to change that. So the 5-year forward view, which is our previous strategy, developed a whole set of new care models that moved much towards a more integrated approach. And I'm sure, again, many of you in the room will be involved in that. So from a patient's perspective, from a citizen's perspective, you all know that care, particularly if you have a chronic condition, is just too fragmented at the moment. It's too siloed. Often you go from pillar to post between one hospital department and another, between primary care and secondary care. And that is not only frustrating, but at the very worst, it can lead to poor care. So our duty, and renal medicine is a great example of how we are doing this and how we need to do better. We need to join up that care once again. And one of the ways in which we will be doing that is by developing integrated care systems in which we ask populations of around 250,000 to 500,000 to come together and for the clinicians, for the managers, for the commissioners and for our partners such as our local government colleagues to work together to provide much more joined up care for citizens. Some of you will be part of that in the really high-flying integrated care systems such as Surrey Heartlands and Frimley that are already up and running, South Yorkshire and Bassetlaw, but some of you will be in systems that are only just getting going. And I would really encourage you to get involved as clinicians, and I don't mean just doctors, I mean all clinicians, into those integrated care systems, because it's in those systems that you will be designing and working on the patient pathways which will deliver much more joined up care for renal patients. Now, beneath integrated care systems at population size of around 50,000, the long-term plan has also established primary care networks. And primary care networks are just actually last month and this month just being formed. So this is the future of general practice and primary care. And the ask here is that primary care and general practice starts to work at bigger scale. We don't care how that scale is delivered. It doesn't have to be a single organisation. It can be a collaboration between a group of practices. But we do want primary care to occur more at scale. For a number of reasons, that provides flexibility in those networks in order to do things differently. And it allows us to put additional staff into networks. And we have promised as part of the newly signed GP contract in England, which follows on from the long-term plan, to put around 7,000 additional staff into those networks. And those staff are not doctors and nurses, because we are focusing on doctors and nurses anyway, but they are pharmacists, physiotherapists, paramedics, social prescribers and others, part of a multidisciplinary, multi-professional team that we think will really give a boost to primary care. And there are a number of practices around the country that are already doing this. I could take you to practices where your first point of contact will be a pharmacist or a paramedic, where home visits are done by paramedics and pharmacists. And of course, those professional groups, and many of you will be in the audience, have a set of skills that complement traditional primary care. And it's through those networks and through those groups of professionals that we will actually be able to do the how in terms of addressing cardiovascular disease. So in that GP contract, in those primary care networks, are service specifications to identify people with high blood pressure, to manage people with high blood pressure, to identify people with atrial fibrillation who are at risk of stroke. So that's the toolkit, that's the staff, that's the model, the multi-professional model, which we believe is going to make a real impact on many of those conditions that I talked about earlier. So I would also ask you to get involved in your primary care network. So every primary care network will have a clinical director. Those clinical directors are just stepping up at the moment. And for those of you that work in local healthcare systems, go away this week and find out who your local primary care network clinical directors are and start having conversations with them about how renal disease and the renal community can get involved in the development of primary care networks right at the start. So, system is changing, much more collaborative. I think that will be much better for the patients that we all manage, and I need you to get involved in these new structures and systems to make that happen. Third thing I'd like to focus on in the long-term plan is digital. So, you all know that when industries are digitized, they are revolutionized. And you also know that the digital revolution has been slow to get to health. But it is happening, and it will be happening quicker and quicker over the next decade. And it's a really exciting opportunity to use digital technology to do things differently. Now, in this space, my future world is a world in which the patient, there is a paradigm shift, and the citizen is the owner of their health data. No longer should you need to ask the hospital or the general practice to see your own health record. You will be the owner of health data, which you will share with professionals and organizations who want to see that. And you will be able to view that in whatever way you want, using whatever apps or front ends that you want to use. And that will drive a real shift in citizen and patient empowerment in health as well. And it will also allow the integration of data that comes from non-traditional sources, so wearables and other sources of health data. So that's a really exciting future, but it does mean as clinicians we will need to think differently because there will be a paradigm shift. It also requires interoperability of IT systems, and of course that is a huge focus at the moment of the NHS, and particularly of NHSX, which is the new organisation within NHS England Department of Health that will be driving this forward. But in the renal community, I think renal has been ahead of the curve in IT. So I know all of you, pretty much all of you, will be working with digital systems, IT systems for patient records, irrespective of whether your own organisation has a comprehensive electronic patient record or not. And there are really great examples in renal medicine of innovation in the digital space. So you will recognise Patient View up there, that I'm sure everyone in this room is familiar with and gives access to patients. So renal was ahead of the curve in terms of enabling our patients to see their results and to see their results before professionals did. So on that path of enablement and paradigm shift. The NHS app is in the middle there, but at the bottom is Streams. So Streams is close to my heart because, of course, Streams was first used at the Royal Free, and it attracted a good deal of controversy. But in terms of what it actually did, I think it's been a great move forward. And really what it does is something very simple. It takes the national algorithm for acute kidney injury, but it automates the process of running that algorithm, and it uses common technology, which is simply push notifications and an app-based user interface to alert a specialist, i.e. nephrologist, of a potential case of acute kidney injury, actually before the team that's looking after the patient know about it. So it takes out 3 causes of unwarranted variation. The unwarranted variation of interpreting the risk of acute kidney injury, which is what the national algorithm does. The variation of timeliness of response, i.e. no longer waiting for somebody to look up a result or miss a result at worst. And then the variability, the unwarranted variability of expertise to interpret those results by pushing the notification direct to a renal physician. And so if you think about that simple way of taking out unwarranted variation, then let's scale up into other digital pathways. There is a huge opportunity to do something that I don't believe we do as well as we should do, which is to apply all the guidelines and standards that we write and we develop so proficiently into day-to-day practice. So renal medicine has led the way here. I know Streams is expanding, but I think there are a huge number of other opportunities in this space. So my challenge in this area is for you to really think creatively and to start to think what those apps are, what those digital methods are to really enable patient care, to really think about how you might be able to drive self-help. You might be able to work for the renal patient, for patients suffering from renal disease, what a self-help app pulling in data from hospitals and other sources might be. So we've innovated in this space. Let's see more innovation. My fourth area for you to think about is workforce. So the NHS really relies on its people more than anything else, and without a dedicated, hard-working workforce committed to improving the health and well-being of our citizens, the long-term plan would be nothing. And you all know that it is a difficult time for workforce at the moment in terms of numbers. And actually that's not just an issue for this country, it's an issue for many developed countries, and it will become an increasing issue as more countries around the world move to universal access to healthcare and expand their workforces. You may have noticed that yesterday morning we published an interim people plan. It attracted some press. And we've been working hard on this over the last 3 months. And it's a prelude to a full people plan that will be published after the comprehensive spending review, and which we promised in the long-term plan. And I had the privilege of leading the medical workforce component of this, but I was also closely involved in other professional groups, because at NHS England, the chief professional officers for pharmacy, the chief scientists, the chief officer for allied healthcare professions, and the chief dentist all sit within my team. So although it's a medical directorate, actually every profession other than the nursing profession sits within my responsibility. So I'd urge you to read the people plan. It has a number of focuses. It focuses first on making the NHS the best place to work. We know that we need to do more in terms of improving the culture that everybody works in, and that will have a benefit to all staff groups. It focuses on leadership, because leadership and the development of leadership, and many in the renal community are leaders, is really important. And I'm a real strong believer in clinical leadership, again, clinical, not medical. And I think expert leadership that comes from clinicians is really key to driving patient care in organisations and systems. Thirdly, it focuses on nursing, because nursing is our most fragile workforce at the moment, with around 40,000 vacancies, and we need to do more both to get nurses trained, but also bring and retain nurses, and perhaps bring nurses back who have left the NHS for one reason or other. But there is also a section on the 21st century workforce, and this is a section that starts to look ahead and says that in the 2030s, late 2020s, exactly what sort of workforce will we need? Now, I have a view that the multi-professional workforce is pretty well advanced in the renal community. I remember when I first started as an SHO at Guy's in the late 1980s, the consultant there telling me in no uncertain terms that it was the nurses that were most important people in the unit, and the SHOs he could dispense with, but he couldn't really dispense with the nursing team, because they knew everything about dialysis and they knew everything about caring for patients with renal disease. And of course, over the years, we have developed many, many models in renal medicine of multi-professional working. But I think there is more that we could do. So we have redesigned the multi-professional team in primary care, and now we need to go back to secondary care and think, what is the multi-professional, multidisciplinary team of the future? So I would ask you to go away and think in renal medicine how we can go even further. So when I stopped clinical practice about 5 years ago, I was mainly doing renal transplant clinics, and in that transplant clinic there would be typically 4 or 5 doctors doing clinics and 1 nurse. I think we should get to the stage where maybe there is 1 doctor and a much more multi-professional, multidisciplinary team, whether that's pharmacists, paramedics, physiotherapists, social prescribers. What's the role of social prescribers in renal medicine? I think there will be a huge role. So let's think imaginatively. We need to extend the skills of individual professionals. We need to bring in new professionals such as physician associates, and we need to reimagine the multi-professional team. So as we start to do that work, which is really important in terms of the skills that we need to train in universities and in postgraduate training, and is really important in terms of numbers and how we shape the workforce, I think the renal community has a real opportunity to lead on that. So in the last couple of minutes, my final theme from the long-term plan is health inequalities, which I have mentioned already. So we have long known that we have a problem with health inequalities in England and in the UK, and of course in many other countries. And that's not just inequalities of access to healthcare, it's also inequalities of outcomes. So I know that the 10% most deprived of the population are twice as likely to die of cardiovascular disease. I know that if you a member of certain ethnic groups, you are much less likely to have access to early detection of cancer. And if cancer isn't diagnosed early, then of course outcomes are poorer. And the truth is that we have not really been closing those health inequalities. In some areas they are widening. And that's why the long-term plan puts a real focus on addressing health inequalities. And the trick with health inequalities is not to do the analysis and then think about it afterwards. The truth is to design in a targeted approach to reducing health inequalities right at the start. So that's why we have been rolling out programs of screening and case detection for lung cancer using mobile scanners, and we have been targeting those in our most deprived communities where we know that the risk for lung cancer is highest. It's why a few weeks ago I announced that we would be putting £9 million into an enhanced atrial fibrillation program to detect people with AF, and we would target those programs at those parts of the country where we know health inequalities are causing less access to detection and management of atrial fibrillation. So we can design in from the start programs that target health inequalities. And I was really delighted that a couple of months ago, the Kidney Research UK launched their report on inequalities in kidney health, and I was really pleased to be invited to the launch in the Palace of Westminster. And of course, this takes the work of Liz Lightstone, who I know is here and is probably somewhere in the room, and her report back in 2001, which really started us thinking about inequalities in renal disease. And of course, you see them wherever you look. If you are a member of the BAME community, then you are 3 to 5 times more likely to end up on dialysis. We know in transplantation that if you are from an Asian or black background, then you will be waiting much longer for a transplant, despite the changes that we have made over the years to the organ allocation scheme to try and ensure that that is not the case. So there is much more that we need to do in health inequalities, and there is much more that we need to do in health inequalities in renal disease. Some of that is around what we do in the round, around cardiovascular disease, around other diseases that contribute to renal disease, but some of it is specific to the renal community. So transplantation, geographical disparities in dialysis provision and access dialysis, that is within the gift or within the area of interest specifically of the renal community. So my last challenge to you is to not let go of the inequalities agenda. It's really, really important, and if the NHS is about nothing else, it should be around universality of access and equality of access and equality of outcomes. So I'm absolutely delighted that KR UK have revisited this, and I would like everybody in the room to get involved in this work locally to ensure that you are focusing from the start in your programs of work on reducing health inequalities. Okay, so finally, what's next for the long-term plan? Well, the next stage of the long-term plan is for local healthcare systems, integrated care systems, primary care networks, to interpret the long-term plan for their own local healthcare systems and economies. And that's, again, something that I would urge you to get involved in. That will happen over the summer and into the back end of next year. And for all the reasons I've said, it's a real opportunity for renal medicine and the renal community to get involved in the start. Many of these structures, many of these ways of working will be new. And I have a view that if you get in the start of those conversations, you will be much better placed to make a difference for your patients than if you get in at the end. So watch out for the long-term plan coming to your local healthcare system, and ensure that you all as clinicians are fully engaged in the work that will be done to drive better care for the patients that you manage. Thank you very much. It's been a real pleasure to be here today. I'm very happy to take 1 or 2 questions, assuming we've got a bit of time. Love to get back next year. I used to come to the Renal Association and BRS every year. I haven't managed it the last few years, but I will keep trying. Thank you.